Hello and welcome. This is week 6 and lecture number 28, and today we'll be discussing challenges in PCL injury and its rehabilitation. We will also see the conservative versus the surgical pathways involved in the rehab. The objectives of today's lecture are to understand the mechanisms, the grading, and clinical presentation of PCL injuries, to compare conservative versus surgical management indications, to learn the phase-wise conservative rehabilitation strategies for PCL injury, and also to recognize surgical reconstruction principles and their impact on rehab planning. With this, let's begin our chapter today. PCL injuries or posterior cruciate ligament injury is tricky. The ligament is strong, and sometimes the body adapts well without surgery or even without rehabilitation. The real challenge here is knowing when to go for the conservative management and when is surgery the better option. PCL rehab demands a different mindset as compared to ACL rehab. The posterior tibial translation and quadriceps control becomes the focus in this rehab. Each pathway has unique timelines and precautions, which means the rehab plan can't be a copy paste of somebody else's rehab plan. It has to be individualized and specific to the injury sustained by an individual. Understanding these challenges help us to make smarter and better individualized decisions for our patients. Now let us recall the lessons on anatomy and biomechanics that we studied in week 1. The posterior cruciate ligament or the PCL is the strongest ligament in the knee. It prevents posterior translation of the tibia relative to the femur. It also assists in controlling knee rotation movement and contributes to overall knee stability. PCL is stronger than the ACL ligament and it is less frequently injured. But when it's injured, it significantly alters the knee biomechanics and the load distribution across the knee. This is usually seen in a high energy or a high velocity trauma sustained by an individual. The classic mechanism of injury is the dashboard injury, where the tibia is pushed backward during a car crash while the femur maintains its position. Any other trauma replicating this mechanism will also lead to injury of the PCL ligament. Hyperflexion of the knee with the foot pointed down, that is, when the foot is in plantar flexion, such as during a fall in sports, is another mechanism which may lead to PCL injury. While isolated injuries are less common, PCL tears often occur with multi-ligament injuries, which makes the management even more complex. In the 10-year athletic knee injury study, PCL lesions constitute to about 0.65% of sport-related knee injuries. This just shows that PCL injury is a very rare phenomenon in an athlete's life. According to the Scandinavian data, soccer or football was the sport with highest number of PCL injuries. More broadly, contact sports and sports which causes falling or dashboard type trauma, and also skiing to some extent, and sports involving hyperflexion or direct posterior force to the tibia are associated with PCL injuries. The grading of PCL injury is similar to the grading of MCL and LCL injury. These grading of MCL and LCL we have seen in previous lectures. Hence, it will be easier for us to remember the grading of PCL injury as well. Grade 1 PCL injury involves partial tearing and up to 5 mm posterior translation of the tibia over the femur. Grade 2 involves around 6 to 10 mm translation of the tibia when a posterior force is applied to the tibia. Grade 3 represents a complete rupture of the PCL ligament with more than 10 mm translation and no firm endpoint. Clinical tests like the posterior draw and the sag sign are fairly accurate and reliable to diagnose PCL ligament injury. MRI can be used to assess the clinical decision and it rules out other associated injuries along with the PCL. Unlike ACL rehab, PCL rehabilitation has its unique challenges. The posterior sag of the tibia complicates joint alignment. Strengthening the quadriceps is crucial because they act as dynamic stabilizer against posterior tibial shift. The hamstrings, on the other hand, pull the tibia backward, and hence hamstring activation and strengthening must be avoided during the early phases of rehab. Even after surgery, graft healing and achieving stability are more difficult with PCL than with ACL reconstruction. Hence, PCL rehab takes longer duration than ACL rehab. Most isolated grade 1 and grade 2 PCL injuries are treated non-operatively or conservatively. The focus is on strengthening the quadriceps, while hamstring activation is avoided early on in the rehab process. To overcome this malalignment issue, a PCL brace designed to push the tibia forward helps to counter the posterior tibial sag. Conservative care often leads to good functional results, especially in non-athletes. During the acute phase, reducing pain and swelling are prioritized. A PCL brace, which is locked in extension, helps prevent sagging of the tibia. Partial weight bearing is used initially and practiced in patients who tolerate it well. Exercises in this phase include quadriceps isometrics, straight leg raises, and hip strengthening exercises. Importantly, hamstring resistance is strictly avoided. The criteria to progress to the next stage include presence of minimal swelling at the knee, full knee extension and knee flexion of more than 90 degrees, good quadriceps activation and brace compliance without posterior support. The range of motion of the knee is gradually restored in this phase. The caution taken is to not stress the healing ligament. Closed kinetic chain quadriceps strengthening exercises and controlled functional training are introduced in this phase. Proprioceptive drills and balance training help restore neuromuscular control. Weight bearing is progressively increased, always guided by patient tolerance and symptoms. The exercises that can be done are close kinetic chain quadriceps strengthening like leg press and wall sits. Cycling or pool therapy exercises can also be performed, while balance drills constituting of single leg stance and other exercises which include step-ups, lateral movements, and hip core strengthening exercises for conditioning can also be introduced in this phase. The criteria to progress to the next phase include full knee pain-free range of motion, quadriceps strength of more than 75% as compared to the uninjured limb. There should not be presence of any posterior sag in functional positions, and the proprioception and gait has to be as normal as possible. Complete and pain-free range of motion of the knee is restored in this phase. Progression is made from close kinetic chain exercises to more functional training and low intensity plyometric exercises like skipping, jump squats, etc. Progression from low intensity plyometric exercises is then made to higher intensity plyometric exercises towards the end of this rehab phase. Neuromuscular control is emphasized upon and the quality of movement is assessed in this phase. The key interventions include plyometric progression from low intensity to higher intensity, cutting movements and deceleration drills performed by the athlete, sport-specific drills, and long-term neuromuscular training of the athlete. The criteria for clearance to the next stage is strength should be more than 90% of the uninjured limb. The ability to perform hop and agility tests. The patient should not experience any instability during cutting and pivoting movements. And the patient should be able to perform all the functional tests. Slide surgical indications and challenges. Let us now discuss what are the surgical indications in PCL injury. Grade 3 injuries, particularly in athletes, usually require a reconstruction. Multi-ligament injuries are another strong indication for surgery. Chronic PCL insufficiency causing instability or pain also necessitates surgery. However, surgical challenges in PCL are graft angle, fixation, and high forces acting on the graft related. This may affect the long-term outcomes of the surgery. The grafts used in PCL are similar to that of ACL reconstruction, like the BTB graft and hamstring graft. Allograft such as tendo-Achilles and peroneal graft are also used in some cases. Graft healing in cases of these injuries is also slower than that compared to the ACL. So, weight bearing and a range of motion must be carefully progressed in cases of PCL injury reconstruction. Hyperflexion is avoided in the early phases of rehab to protect the PCL graft. Muscle strengthening focuses on quadriceps, while hamstring strengthening is delayed until around 12 weeks of rehabilitation or till phase 3 of the criteria based progression. Full return to sport may take around 9 to 12 months of extensive rehab under supervision. Return to sport requires pain-free and full knee range of motion. The quadriceps strength of at least 90 to 95% compared to the opposite uninjured limb. Successful completion of hop and agility tests. Patients must also not complain of any instability symptoms while performing these tests. Investigators can look at the patient's face while they perform these tests to look for any grimace during the test. Clearance by the surgeon and the sports physician is essential before making a full return to play. With this, we come to the end of PCL rehab protocol. To summarize and to mention the key takeaways are PCL injuries are less common but challenging. Conservative protocol is good for most isolated low-grade injuries, and surgery is recommended for high-grade or multi-ligament injuries. Rehabilitation emphasizes on strengthening of the quadriceps muscle, while hamstring strengthening is avoided in the early phase. Criteria-based progression helps for a safer return to sport. With this, we come to the end of PCL rehabilitation. In the next class, we will discuss about meniscus injury. Till then, thank you and goodbye.